Good evening, everybody. I'm Professor Rungan, past president of Wonka Europe. It is nice to be together with you tonight. All together, we will today discuss about the controversies in cancer screening, gastric cancer. The gastric cancer is fifth common and fourth most killer cancer worldwide, and its screening remains one of the controversial topics. 75% of all new cases and all deaths from stomach cancer are reported in Asia. Although it's very rare in Northern Europe, Central and Eastern Europe has the second highest prevalence. Primary and secondary prevention strategies are the focus of stomach cancer prevention. Between 30 and 50% of the cancers can currently be prevented by avoiding well-known risk factors and implementing existing evidence-based prevention strategies. The burden can be reduced through early detection of cancer and appropriate treatment and care of cancer patients. Like others, this cancer also has a chance of cure if diagnosed early and treated appropriately, although a 5-year relative stomach cancer survival rate of about 20% is observed in Western developed countries and in developing countries, according to an international comparison of data from population-based cancer registries. Upper GI endoscopy is the gold standard for stomach cancer diagnosis and used in screening in a high-risk area like Japan, Korea, Venezuela, and etc. But the procedure is quite expensive, unpleasant, and has a risk, while the available evidence on endoscopic surveillance of pre-malignant gastric lesions is showing conflicting results. We will ask it to our guests today, but to my opinion, the biochemical stomach cancer screening currently is not yet good via the detection of potential markers of gastric atrophy like serum pepsinogen, serum ghrelin, H. pylori, serum antibodies, gastrin 17, antigastric parietal cell antibodies, as the results seems not convincing, at least not yet. The question is, will you be on the side of screening or not? What is the evidence? If yes, how to screen? Whom to screen? When to screen? If no, why not to screen? I hope this debate helps us to have our clinical judgment. We are with two distinguished keynote speakers with a slightly different two perspectives on this topic. The first speaker is Professor Juan Mendiva, from Spain, and he was, you know him, he was an EB member of the past Wonka Europe executive boards, and currently he is the chair of the European Society, European Primary Care Gastroenterology. He had a PhD in Barcelona and is a trainer in family medicine, and he is a member of the Spanish Primary Care Research Network, as well as an active family physician with an interest in GI diseases. Our second speaker is Professor Māsis Leja, Latvia, Riga, Director of Institute of Clinical and Preventive Medicine in University of Latvia, a consultant gastroenterologist. He worked in the European Cancer Mission Board from 2019 to 2021. He is a member of the Research Committee of the United European Gastroenterology. I wish we will find the answers of our questions, and I wish you will have a fruitful debate today.
Hello, Hello, good evening, everyone. My name is Juan Mendive. I'm a family physician in Barcelona, and I'm very happy to be with you today. And I thank Wonka Europe for giving me the possibility to participate in this debate today, especially thanks to Ferdinando Bertolucci for inviting me and for Memen Hangan to coordinate this, and my colleague also, Marcis Leja, to participate with me in this venue, and trying to provide a perspective from the gastric cancer screening and a vision from my vision in primary care in 2023. I'm an active GP, so there will be some questions I would like to answer from this presentation. For instance, should a GP screen population for gastric cancer to everyone? To who to screen? If we are going to base this screening on any particular risk, for instance, age of people. What about the supporting evidence? Who is doing us that possibility? What about the outcomes we're going to measure from this screening process? We're going to avoid increasing cancer incidence, mortality for cancer. We always have to consider the quality of life issues. There's an important ethical implication here about when we talk the screening process include what is the health system going to provide to the people. And that is an accessibility situation that is not always aware in every single health system. So this is something also to consider when talking about screening cancer programs. We do have some very good examples. I'm not going to extend about the colorectal cancer screening program based on FEOBT or colonoscopy for people over 50s or whatever. Also, breast cancer screening that have been taken for many years in different countries based on mammographies, on a threshold of women on a risk, and also important other programs like the cervical smears PAPs cancer screening for many years in different countries. Sometimes primary care is not taking a leadership role in these kind of programs, and maybe in some countries are the public health authorities who runs the program. But this is different from countries to others, as well as the controversial screening programs, as the one, for instance, for prostate cancer screening or the lung cancer screening smokers. I know Wonka has also provided other webinars about these conditions. The situation is always controversial, and for me, it's very, very relevant to consider that will be always an issue about shared care decision process with patient and the non-harmful principle primum non nocere, I would say in Latin. So always patients on the middle and try not to make any damage at all to patients. And the equity in access to services is also of a relevance. As being in primary care, I'm taking here with you in a scenario of one of our patients. John is a 45 years old male coming to practice for an epigastric pain for 2 weeks, not having that complaint before. He tried antacid OTC, but it's not getting better. Seems like it's a little bit worse after meal and has no other complaints. He's a smoker of 10 cigarettes a day, social drinker, maybe 8 units a week, and he comes to us because of the problem. At the end, we decided because of the pain to make a test of Helicobacter pylori that finally was testing positive. So we prescribed a quadruple therapy with omeprazole, clarithromycin, amoxicillin, and metronidazole to him. And that treatment was successful, at least in improvement. And after another test 1 month later, so negative pylori testing. So he was okay. Primary care is always an issue of following up patients. What happened to him? John comes afterwards, about 3 months later, explain again, pain in that epigastric area on postprandial situations, and even a little bit of heartburn, and again, with no improvement with OTCs. So we decided, because of the situation, because of the age, because of the recurrence, to order an endoscopy. And here we had a mild erosive antrum with results of pathology that was showing us moderate areas of chronic gastritis with some gastric atrophy. So, colleagues, this is something we can find very, very frequently in primary care when we ask for an endoscopy. And what we do with John? what are we going to do in primary care? Is there any risk for that? Is there any follow-up necessary? I'm going to try to ask these questions in these few minutes. So when preparing this with you, for you, I was trying to find what was the situation. And I found first this web on the Research UK, and it's addressed to population, to people who may be wondering about what we have to have related to a screening of cancer, of stomach cancer, of gastric cancer. And the answers here are very clear. There is no national screening programs of stomach cancer in the UK, no gastric cancer screening program, because the situation is not for that. But there may be some situation that may be having benefits for people who may be benefit because they have an increased risk. So whenever, and you have here on the button, whenever you have this negative answer, you have to ask to have an answer why we don't have a massive screening program, because the type of cancer, this is the gastric cancer, is relatively uncommon. That means the incidence and the prevalence is not that high, at least in Western European countries. And then the benefits of not having don't outweigh the costs. There's always an issue of cost and effectiveness of the interventions when we are talking about screening, massive screening programs. And this is something to consider. This is why it's clearly established here, and to show to the population that there's not a real need for that, at least for the population based. But it's very different when we talk about people, at least because they may be having some specific conditions. This is just a slide to show you that in some very, very specific genetic gastric cancers, that there is a need for having those tests, and the primary care implication in this cases should go always to the specialist care. But it's need always to avoid this kind of problem on gastric cancer is the test and treat for Helicobacter pylori, and even the surveillance, the looking into the stomach when necessary, and to see what's going on. And when necessary, some very early, very few patients, hopefully, are even needing to have a gastrectomy sometimes. But this is just very, very, very few. We're not talking about problems in a massive way. So the current recommendations, as I was telling you, and in the US Preventive Task Force says that we don't have that need for population-based screening. And at the moment, they are developing a guideline for Helicobacter pylori. NICE or SIGN or Australian or New Zealand guidelines, neither of them are actually having recommendations for population-based screening programs for the whole population. But China, Japan, and other Asian countries like Korea, they do have screening programs because their population is a much more higher risk. And this sometimes is based on score, as I'm going to explain you in a minute. So when I was telling you just a few minutes ago is that the cost effectiveness analysis are crucial in order to determine for the ones who have having decisions, the decisions maker people from health systems, how to invest or not for making gastric cancer screening programs. And in Western countries, according to this publication and to other elements, we don't have the evidence that clear, because we have different situations to consider. And on the left side, you see the primary care implication. And usually for us would be from the healthy people into the Helicobacter pylori, and even to the detection of atrophic gastritis in some cases. But from here, then how we're going to go or not for endoscopic screening and surveillance, that the evidence here is not that clear. And there's an incoming interest for the serum pepsinogen testing, but again, there's no real evidence for the effectiveness or the cost effectiveness of this and surveillance for the following situation through this when we are detecting patients on atrophic gastritis. So there's a gap here in how to deal with this when this kind of situations. And anyway, if we have someone already with some findings, we are not talking about massive population screening. We are talking about a specific people with already some finding. There is a consensus that was published a few years ago about how to deal with diagnosis of gastric gastritis. That was done through a Delphi consensus process, and the elements here were very clear. They were based on national situations of different countries. Here you see on the slide how Japan, Korea, or China, for instance, have very, very relevant conditions of incidence of gastric. Other countries in the bottom part of the slide, for instance, the incidence is very low. So the situations and the development of the guidelines of the need is very, very different. The recommendations, when according to this publication, is very different when we're talking about high quality recommendations. And just for us as primary care providers, you see on the top of the slide, or the situation we have to carry about is about people who may be having two situations, that is an infection of Helicobacter pylori and there's a chronic atrophic gastritis. For these people, for instance, there's a high quality evidence or providing a surveillance for the future situation of finding if there is maybe a risk for having that gastric cancer, but not for the most amount of our patients, even for those who will be having infections of Helicobacter pylori, if properly already eradicated. And not much more evidence. Most of those, the recommendation they have in the publication were very low quality. In Japan, as in China and other countries as well at the moment, they have included the gastric cancer screening for the whole population as something to recommend, as they recommend also breast cancer or the colorectal cancer screening programs. So you have to know that this situation is very different from Japan, etc., than in our countries. This is again a publication from the what they call the SCORE methods, and you can see here in this publication how they measure a very appropriate SCORE method they have been building in China in order to have a screening scoring system for cancer, gastric cancer in China, based only on some parameters who are not having any kind of infection at all for patients. So it's very few harm. And this is age, gender, antibiotic of Helicobacter pylori, and serum peptidogene 1:2 ratio, and gastroenterine 17. So just with sample of a blood sample and some few parameters, we can develop a very nice risk that can be making a helpful situation for this kind of massive screening. And this has been compared to another classification that is called the Kyoto classification for gastric, and that was based mainly on endoscopic findings. Anyway, well, I just want to show you that we do have these kind of scores in these countries, and you have seen the button as well that has been seen, that was published in that paper as well, how most of the amount of patients who were suffering from gastric cancer had already infection and were on high risk for that, were having infection of Helicobacter pylori. So from primary care, recognize that infection is just crucial. Also for you to know that some specific populations in United States, for instance, also this apply to some indigenous population to the New Zealand. They may be having the need, and it's cost effective according to different analyses to provide this kind of screening for this specific population, and that these kind of screening programs may be cost effective in these countries. So it's very important to know as well all that. This is some of the outcomes from that program, where that surveillance for people who were already maybe having some endoscopic findings, and doing those surveillance for every 3 years was shown to be cost effective for the population. So there's important knowledge here to know. I mean, and to provide to this population that sometimes even can be population of poor environments. For these people specifically, it might be more important to provide that training. Just to show you also to make you aware that the British Society of Gastroenterology have provided guidelines for surveillance of screening for gastric carcinoma. You have here published on GATS a few years ago, and the primary care role in the process is mainly for making the people who may be at risk because of the findings to follow the appropriate path. I'm not going to extend here, but just for you to know that we do have that, and that, however, because some few years ago was established what promising the biomarkers may be in this process of the screening process, the evidence still is quite insufficient to support the screening in low-risk population. And this screening now should be still much more extensive and necessary for people who are having gastric atrophy or intestinal metaplasia. And these one will be the ones in which we have to be more focused from even our situation in primary care. I make you aware about this publication in Surgical Oncology, the new advances in screening and detection of gastric cancer, and I would like you to know that we do have some few good news here and new evidence for you to know about how it's important for us, even in primary care, to have the knowledge of this new development. Just for finishing, art and science always together, and even more in primary care. Although the experience is the art and the scientific evidence may be the science, this never should be opposite, and we should carefully acknowledge the importance in balancing each other to have good clinical outcomes. This is art and science always together for the best outcome, and always together the best in clinical practice and the best for our patients. And just for conclusions, there's no in the screening program in general, universal, general for population in primary, and even thinking more in primary care. See if we can answer yes, that in some countries this program can be something relevant in Japan, China, and Korea, concrete. Also for some countries like USA or New Zealand, specifically for some immigrants or indigenous population, can be something relevant. But we have to be aware, and this is where I have to remark, and it's very important from a primary care perspective, whenever we can, to test and treat, because Helicobacter pylori eradication is the best tool we can have in primary care for making the cancer, the stomach cancer, the gastric cancer less prevalent. So, and at the end, just to say that surveillance of patients at risk, the ones with gastric lesions, and the coordination with GI specialists, endoscopies, and providing the necessary surveillance, it's a necessary tool as well. Thank you very much from Barcelona. This is the picture from my practice, and I would like to have your views on this talk and on this situation, and hope to see you in the next future. Thank you very much.
Good afternoon. My name is Mārcis Leja. I'm a gastroenterologist from Latvia, and I'm really happy to be here on the WONCA meeting and to present the viewpoint of specialists in respect to gastric cancer prevention. So my task for today is to provide the existing evidence and hopefully to convince you that gastric cancer prevention has to be implemented in Europe. First, let's start with very brief information on the epidemiology. And as you can see from the map, the incidence figures between the countries globally, but also between the countries in EU, are substantially different. And that is not really a surprise that specialists from low incidence countries do not see the problem so frequently, although currently the situation is also changing with the immigration. And this is also true that the incidence, if estimated in the age standardized ratio, is declining globally and declining in Europe as well. However, due to aging population and in many countries increasing population, the total number of new cases is not going to decrease. Vice versa, it's going to increase during the upcoming decades. And how this would reflect to Europe. Similarly, also the burden in Europe is expected to be increasing during the upcoming years. And as you can see from the chart on the bottom, the cases that are reflected in red are the number of new cases that are expected to be in Europe, either in incidence or in deaths as well. Furthermore, what we are currently estimating that at least 35 to 40% of those deaths could be prevented. So meaning that large number of those cases could be prevented in the case if implementing screening and prevention activities. And we are going to speak a lot on Helicobacter. That is the main etiological factor of gastric adenocarcinoma. And actually, it is responsible for approximately 90% of the non-cardiac gastric cancers. That is a majority of gastric cancers. And by considering this, already back in 1994, the IARC working group has named this as a first-class carcinogen that has been further reimbursed by WHO much more recently. Yes, we should consider that a large proportion of global population is infected with the Helicobacter, and that definitely has to be considered in the prevention programs. However, this high prevalence of the infection is not similar across all the countries in Europe. So going back to 2015, when the Kyoto Global Consensus on Helicobacter gastritis has been accepted, this was the first time when Helicobacter gastritis was named infectious disease. For decades, it was debated, and at this date, it was really named infectious disease. Furthermore, actually, currently, by the recent European guidelines, Helicobacter is called as a true pathogen, what has been really once more a debate. And coming back to the Kyoto Consensus, it has recommended that all H. pylori infected individuals should be offered eradication therapy unless, of course, there are any severe contraindications really to do this. And what we could achieve with eliminating Helicobacter. This is a recent meta-analysis from Alex Ford and Moyedi group published in 2020, either in Cochrane database or in GOT, that is a leading gastroenterology journal in Europe, providing the meta-analysis that by eradicating Helicobacter, the risk could be even reduced more. So the relative risk reduction would be 0.54. And namely, this means that only 72 individuals need to be eradicated to prevent one gastric cancer case. And the same relates also to mortality. The number needed of treat is a bit higher than for incidence. That is very logical, 135, but it is one of the most effective tools to prevent any type of cancer because this is a small number of subjects that should undergo eradication treatment to prevent one cancer case and cancer mortality as well. So when to eradicate, and that also has been debated for years. What we know quite well from multiple guidelines, including this recent European guidelines, is that it is best to eliminate Helicobacter before severe precancerous lesions have developed, and namely this would be in early age group instead of really elderly people. However, the recent guidelines are saying also the following, that there will be effect of H. pylori eradication at any age at adulthood. We are not speaking about eradicating in childhood, that is different story. We are speaking only on adults, but with the age, the effect is decreasing. There is also a suggestion to use the strategy during the colorectal cancer screening programs, but we do not yet have really very solid evidence for doing this, but this could be considered. Furthermore, I have mentioned already a couple of times the precancerous lesions. Why so? And this is a cascade of gastric cancer development that was proposed by an American pathologist, Pelayo Correa, back in 1975. And this cascade still stands and is considered in the process of cancer development. So from normal mucosa, the lesions are undergoing through gastritis, meaning inflammation, then atrophic gastritis, intestinal metaplasia, dysplasia, and finally a small proportion of those cases is reaching adenocarcinoma. At the time Pelayo Correa was proposing this cascade, he didn't know even, and this was identified later, that during the process of switching from normal mucosa to superficial gastritis, Helicobacter is a factor that really is responsible for this. But there's another part of this chart, and actually in the case, if we are able to identify at a timely manner the high-risk precancerous lesions, in this case, we are able to follow up those individuals and identify the progression to the cancer early enough to treat them, or be able even to treat the lesions prior than the cancer has developed. So how to identify the precancerous lesions? There could be several ways to do this, invasively by endoscopy, or non-invasively. That absolutely would be the recommended strategy, however, with some limitations. We could be proud in Europe because we were the first to have the recommendations on how to manage the precancerous lesions, called MAPS guidelines. And currently we are living already with the second version of those MAPS guidelines, what are clearly defining how precancerous lesions have to be surveyed in Europe. So what about the non-invasive markers? And the most studied of those are pepsinogens that seem to be very attractive markers and really the best available right now. But please pay attention to the figures of sensitivity. So a substantial percentage of the cancer cases would be missed if only we are using this non-invasive screening method. So it could be used, but probably not as a single method. To summarize what I have been saying before, if speaking about screening gastric cancer, we need to understand what we are screening. Are we going to screen for cancer itself? Are we going to screen for precancerous lesions or for Helicobacter? And here we do have the approaches: endoscopy for cancer, and that is being used in Asia, probably not suitable in Europe. For precancerous lesions, we can also screen either endoscopically or non-invasively. And for Helicobacter, that would be the screen and treat strategy with identification of Helicobacter in otherwise healthy individuals. A couple of years ago, we have been conducted a survey by addressing specialists from multiple countries and multiple specialities. I have to say that the majority we are gastroenterologists, and we have got quite good coverage of the global countries. Definitely not, the proportion was not perfect, but nevertheless. And what the responders were, what was opinion, for most of the specialists, the opinion was that population-based screening for gastric cancer is feasible and has to be introduced. So where we are right now, and as you know, the European Commission is recommending to go in the way of gastric cancer screening implementation. Currently, a TOGAS project to address the issues and to provide the recommendations will be launched within the next couple of days. And the objectives of the project is to assess the state of the play. And actually, we are recognizing that not all of the specialists, in particular in primary practice, are really so much convinced as the experts I was showing from the previous survey. So we are going also to perform survey of medical staff, and we would be very happy to have intense viewpoint from GPs, and I would be really very happy to have Wonka involvement into this survey distribution. Then the project is going to address the appropriateness of various gastric screening modalities, and I will show the modalities in the next slide. And furthermore, distribution of the acquired information and addressing the methodological aspects. So those three are the studies that will be conducted within TOGAS project. Pilot study number 1, and that will be the first one to be performed in EU in this respect, by searching for Helicobacter and eradicating at young age individuals, namely 30 to 35 years old individuals. Pilot study number 2 will be addressing the possibility to combine gastric cancer prevention to colorectal cancer prevention. And finally, pilot number 3 is going to address the undesired adverse events from eradication therapy in long run. And we are going to have annual special conferences on the topics, and the next one would be held in Antwerp in September of this year. So once more, I will be more than happy to welcome Wonka representatives there. So in summary, let me conclude that there are good possibilities and several approaches to prevent gastric cancer-caused mortality in Europe. Based on the current evidence, population-based screen and treat strategy for Helicobacter, in particular in young age individuals, appear to be the most effective and also cost-effective approach in Europe. However, before broad-scale implementation, we need to perform implementation research, and that will be on the way. And finally, what we can do right now is to assess properly gastric cancer precancerous lesions and to submit the subjects in whom precancerous lesions are being identified to the surveillance strategies. With this, I would like to thank for your attention, and I hope you are pretty much convinced that gastric cancer prevention should be implemented in Europe, but we are still on the way to provide the best available recommendations. Thank you.
Thank you very much, Masis and Juan. Those two very interesting and very informing presentations really raised some questions. The first question from the question and answers section is, can we say anything, Masis, about Helicobacter pylori for the kids? The question is, for the kids, do we consider any clinical condition?
if I may start to answer on this, actually, when speaking on gastric cancer prevention, we are speaking only adults. So for the kids, the situation is completely different. And we do not recommend to test Helicobacter non-invasively in kids. What we do recommend in adults. The reason for this is that, first of all, proportion of kids is going to clear the infections themselves. And on the other hand, in the kid age, we still cannot be so sure on really the harms of the treatment versus the benefits of the eradication. Therefore, Helicobacter is being managed in kids in the case if it is peptic ulcer, if it is probably also dyspepsia, but in this case, endoscopy has to be performed before that.
Yeah, thank you. And maybe another question came, screen and test strategy will be directed to non-symptomatic people. Is that right?
Actually, this is currently what is already recommended by the guidelines, and that I think requires, and it's very nice that we do have this debate, because it's really not only pros, there's also contra arguments for the such strategy. This is called screen and treat strategy. Screening for Helicobacter in individuals that do not have any complaints, and eradication if Helicobacter is found. That is currently the recommended strategy by the specialists. However, to implement this on a population-based level, we still need to have more evidence, as mentioned really in implementation research. And actually, thanks to my opponent, Ioan Mendive, for his great presentation. I think all the points that he brought up were highly relevant, and I hope that we are going to address them.
Well, thank you very much. If I can also make a comment, a couple of comments here. Professor Martis Lehe, you made a wonderful presentation, and I think we've learned a lot from your expertise and from your very relevant data. And I think this is obviously is an area with a lot of improvement to have still, because we have a lot of doubts from the primary care perspective, and some of them hopefully have been having more solutions and more learning. I've just taken your leadership and you explaining about the STOGAS project. I think this is great, and to have more information from this project will help to take decision-based processes in primary care for all of us in Europe. I explained a bit about situations in other maybe countries in the world where the prevalence of the stomach cancer, the gastric cancer, is higher. For us, we do have a lot of uncertainties in the day-to-day practice, because the incidence of and the prevalence, hopefully, of this cancer still is not that much. But the issue of Helicobacter pylori infections is really very relevant. I just presented a case of someone who was suffering from symptoms, but we may have the issue of are we going to make a massive screening for population? And there's some publications already that we already know very well that have highlight the debate about identifying perhaps very young people and trying to and then provide antibiotic therapy for very, very much amount of people around Europe, around the world, maybe having also side effects, implications that we don't know. What about microbiota, who's going to be having an implication of that as well? So a lot of things that we don't really know exactly what's going on, but it's very important, perhaps, in the future I see here is in identifying the possibility of a screening process, in screening and treating Helicobacter pylori infection, maybe to target a proper population, maybe in those countries, even in Europe, where the prevalence of infection is higher. Maybe we should target specifically with situations where we're going to be more cost effective and causing less harm to this population. So maybe I think the trend is to that way. And I really thank the awareness from the European Union about and this warning about having this issue of the cancer gastric, and I really appreciate it, and thanks to all the people who have been participating in the session today. Particularly, I would like also to thank Professor Shlomo Winter, President of Wonka Europe, to invite me to participate here because of this warning about the situation of the gastric cancer from primary care perspective, and to provide this vision from my vision in primary care in a daily practice. Thank you very much.
And also, there is another question for our guests. The problem of antibiotic resistance was raised. How do you see it after extensive case finding and treatment? It's very live topic about the antibiotic resistance across Europe, especially Eastern Europe.
Yeah, I can wait. Yeah, but Marcis, are you answering this about the antibiotic?
I could try to do this, but maybe before addressing this, I would really comment a bit on your latest comments, what you mentioned, and indeed, I cannot agree more on what you have said. Ideally, we should identify the group that is at increased risk. But the problem is that we are not very good in identifying this group. We are not speaking about hereditary cancer. That is a different story. Very infrequent, but this has to be identified in a different way based on the family history. We could really try to identify based on pepsinogen tests, and that would be a very attractive approach. However, and we have just published a paper in this in the European Journal of Cancer Prevention, we would be missing 2/3 of cancer cases if searching for pepsinogens, and pepsinogens would identify only late stages of the atrophic precancerous lesions. Then, of course, we can try to define the risk group based, and that has been a very attractive approach because Helicobacters also could be different. But unfortunately, this hasn't been working so far. So for the time being, we do not have a good tool for risk stratification. And that's the reason why the recommendation is to eradicate all this is the citation from Professor David Graham that good Helicobacter is only dead Helicobacter. But I completely agree that this is expected to be related to adverse events. And most importantly, what you raised about resistance in gut microbiota. And this is really a concern. And actually, we have been looking into this, and there have been a number of publications on this. And currently, things, and I didn't expect this, but still that this 14-day or 10-day treatment regimen does not significantly increase the resistance, except for clarithromycin resistance.
Right.
And then coming back to the questions that we have received from the audience, generally, the recommendation currently is 2-week eradication treatment unless a shorter duration has been proven effective in the particular territory. Exception is the quadruple therapy, what you have been using also in your patient that you have demonstrated. And quadruple therapy is still one of the best choices, achieving the best effectiveness success rates there, but definitely the resistance issue is there, and we know that the number of deaths caused by resistant bacteria is going to increase steeply. We do not want really to harm more with giving broad spectrum of antibiotics. So for the time being, I would not recommend immediate implementation in all the countries by GPs, eradication treatment to everybody, but we need really to see and maybe to have better therapies, like quadruple therapies that are not available in many countries, to be used for the purpose, avoiding clarithromycin, avoiding levofloxacin in the schemes. So those are really the aspects to be still evaluated, and that's why we really need those results still. But generally, probably at the moment, the best approach is really eradicating, and most probably young people. There is another benefit for giving the treatment to young people, because we know that the transmission is occurring mainly in the families. So in the case, if we eradicate before children are born in the families, we just stop the transmission. That's another important aspect as well. But once more, we need really to prove some of the aspects, although we do have a lot of evidence already in this respect. Thank you.
Yeah, this is very important, really. And as I remember, many years ago, one of the concerns were the quinolone type of antibiotics would be a threat for the tuberculosis resistance. And I think it was a great warning at that time. So for the same thing for the clarithromycin, for some other infections especially, they became a little bit useless. And I remember we were using 2 antibiotics at the beginning, and then it came to 3. Sometimes the authors recommended 10 years ago 4 antibiotics, and in the primary care, many countries raised the, by unnecessary use of the antibiotics. For some cases, it was a difficulty for the microbiota also, for sure, and for the resistance. So can I ask you about the history? I mean, as much as I remember, the number needed to treat was 72 in your presentation, and but I remember maybe 10 or 15 years ago it was like 30 or something. Is there a change, or what is the reason for the change of number needed to treat? Do you think is there a specific reason?
I believe that it depends on the target condition. And for cancer, at least, and this is the most famous group of meta-analysis, and of course we could desire more studies in the meta-analysis, but still it's Paul Moyedi's group from Maastricht University, who have recently calculated that number needed to treat is 72 to prevent one case, and 135 to prevent 1 death from gastric cancer, and that is actually very effective treatment. Yes, but yes, there are definitely other numbers for other diseases, and for instance, if we speak about functional dyspepsia, and maybe that was indeed the patient that Professor Mendiu has been describing. So that is not really a surprise that if the patient has functional dyspepsia, symptoms and maybe pain in the stomach, and the symptoms do not go away with the Helicobacter eradication, that is absolutely acceptable, and that is what we know. And actually, very important aspect, what you mentioned, I think, is this shared decision making with the patients as well. We can communicate before proposing the treatment to the patient, because really we need to treat 16 patients to achieve the complete regression of dyspepsia in 1. Yeah, so it is not very effective in that sense. 1 from 16, that is quite small number, but nevertheless, so it really depends on the target disease. Mm-hmm. But I assume if there were different numbers on gastric cancer prevention, it could be, but probably those were based on the publications that were available that time. That is what I could explain, at least.
And I think the benefits and harms are usually estimated by number needed to screen, and it should be lower than 1,000 for, I think, for any effectivity if we are talking about, especially the number needed to screen is changing. In general population, it's over 1,000, but for the risk groups, it's around 400, which is a great difference. So I think it's showing us that we have to target some groups, especially risk groups and risk factors, in order to screen. If we are deciding at the end to screen, I think it should be the risk groups to be screened according to what I understood.
If I make a comment here, because I think this is just the key relevant aspect that we should be trying maybe to target for the future, and hopefully it's going to be a close future, as Professor Leja was explaining before. And they've been working a lot on that, and I'm aware about that, and congratulations for this excellent work you've been doing. But I think we still need that very good specific tool that can be used widely in primary care, and that can be a relevant tool for us in order to screen these appropriate patients and not to miss ones and not to do too much screening massive. It's not necessary. So to have to target as specific as possible. And this is, I think, something that we'll maybe take into account. Obviously, perhaps, I think, obviously, Helicobacter pylori infection in some way, maybe other biomarkers that we don't still have too much knowledge about them, maybe are not related to plasminogen, or maybe yes, or something more specific. But as much as we can go that direction in order to be as specific as possible for doing this necessary screening for our patient, that will be, I think, what we need and much better. So I think the floor is for us on that direction. And from the European Society of Primary Care Gastroenterology, ESPCG, we are the ICG in Wonka Europe. We will be very open and helpful to collaborate as much as possible in whatever initiative on the sense on the TOLES project, or any other that may be arising for this purpose. So thank you very much.
Thank you. And if I could comment on the initiative, because we do have initiative, we acknowledge that really, although the data, what we have demonstrated on the specialist viewpoint, but we need indeed the general practice and also the gastroenterologist viewpoint in general practice. And we need to understand very well all the barriers and motivators as well to be involved, and maybe suggestions. And for this reason, what we are going to launch the TOGAS project just on this Thursday. And what we are going to discuss and we plan to create is a survey to medical experts, but close to the primary practice and in primary practice. And we would really appreciate the involvement of WONCA and of the European Association of Primary Care Gastroenterology, maybe in translating even the survey in national languages, so to have the close to the everyday practice objective responses. And so we would be really very happy to have this collaboration. Thank you.
Thank you.
Maybe one we should work on together. We should work on in primary care together with our specialist colleagues to raise the awareness. I think the first step is just thinking about it and being sure about the risk factors and red flags in this subject as other cancers, I think. So red flags are always something that we should be told our colleagues. One of our young colleagues were telling me yesterday he never thought that his father could have a gastric cancer. He's a GP, and he's saying that, you know, those red flags later on, it's not staying like in the book, you know, but during the real life, you should remember it also, you should use it. So I think in every time and every opportunity, we have to remind those red flags everywhere. Yes. So MARS is European Society of Primary Care Gastro has been publishing many publications and very effective group of Wonka Europe. And we respect a lot our colleagues, and I am one of the members of it also for many, many years.
Yes, that's it.
Because it's an effective group, actually. So we would be, I think, as our chair says, you know, it is very important to have a kind of collaboration with all specialist groups in order to make the best practice in primary care. Thank you for your participation. And if you want to say something else, I am open and we have time, and otherwise we can close.
What I just wanted to mention that I think the cooperation to primary care at all the different levels is really very, very much important. And we are very happy to be good friends, to communicate, to learn all the issues, the criticism, the barriers, but definitely we see each other as really permanent partners in this. Thank you.
Thank you.
Yeah, just to comment that I really thank you very much also for this invitation again. And I look forward to this collaboration for further interest, for mainly for doing our best in primary care. At the end, that is the best for our patients and the best possibility we can build for them. So thank you very much also for giving me the possibility of taking this floor on behalf of the European Society of Primary Care Gastroenterology.
And I would like to thank all the participants and also Professor Shlomo Winke on behalf of the Wonka Europe Executive Board for those series of those kind of webinars. Shlomo, would you like to say anything about it? Okay, you are fine. So I wish you a good night and wish a very fruitful collaboration in the future. Let's be in touch. Have a good night. Bye-bye.
Thank you. Bye-bye.
Bye. Thank you.
Bye.